2. Hello, everyone. I am so excited to have you join us today. I hope y'all enjoyed your 4th of July week last week and the break from our webinar schedule. And I'm so excited to have my dear friend, Miss Brandy Brimhall, here to kick off the webinar series after our holiday break. And she's really going to be talking to us about documentation and coding for those unproven, investigational, and experimental procedures. You know, there's always these updates with insurance companies where all of a sudden something that once was covered is now considered, experimental or investigational. And so I'm so excited that we're going to have her covering this topic. Brandy has been a driving force within the chiropractic profession. She's been working in it since 1999. Many of you probably remember her from her work with ChiroCode, now currently with KMC University. She is a speaker and author. She's absolutely amazing, let me just say that. She started chiropractic working in a small practice in Colorado, found her passion as a CA, front desk CA, x-ray CA, billing CA, and eventually as an office manager. She has a lot of experience and a lot of knowledge when it comes to compliance, coding, billing, accounts receivable, compliance, auditing. Like, she's truly like the woman. Like, she knows all of those things when it comes to the back office of how to manage and run your practice, which is why we like to invite her to come speak on this webinar series frequently. She has lots of certifications, certified professional coder, medical compliance officer, certified ChiroCode chiropractic coder, certified professional compliance officer, and a certified professional medical auditor. I could just go on and talk about all the wonderful things about Brandy, but better yet, I'm going to turn it over to Brandy so that she can share her wealth of knowledge with you, the audience, today. So, Brandy, thank you so much for being here today.
Thank you so much for having me again. I always look forward to doing these webinars, and actually almost every time I come, well, probably every time I come, it's one of my most favorite topics that I'm getting to share. So today is, again, another one of those favorite topics that I have, and we're going to be going over documentation and coding and just general descriptions of what are unproven investigational or experimental procedures. I know we've probably all heard those terms before, but it's probably not completely clear what that really means and what it means to us, to our practices, to our documentation and coding. One of the reasons I love this topic is because I come from practices that do a lot of experimental procedures. What you'll find as we progress through this webinar and these slides that are up and coming is that there are multiple procedures listed as unproven, investigational, or experimental that you probably wouldn't guess, and many of them are probably procedures that you're providing in your office right now and just don't necessarily realize that you technically really could be at some sort of risk for an audit and would have a difficult time defending yourself because you're performing an investigational type procedure. So let's go ahead and, again, this is like normal. This is going to be an awful lot of information in a short time that we're going to be going over. And I wanted to make sure to give you the absolute bulk of it and the most usable information that we possibly can in this time. Certainly, as always, definitely reach out, because I know, especially coming back from a holiday week, you're still probably trying to get back in the groove of your office and everything that is taking place there. And then these kinds of topics can sometimes just be a little bit mind-rattling. So overall, today what we're going to be covering is really recognizing what those types of procedures are, what the description is of unproven investigational and experimental procedures, how the state boards and payers view them and how they define them within their policies, recognizing some of the guidance from state boards, and some, there's actually informed consent required right here in my home state of Colorado, and I know this to be the case with other states as well. So I'm going to give you a glimpse of the actual Colorado rule, because this is similar among other states, but I'll also send you in the direction to your own state for that type of guidance, because of course we're not just having to follow one set of guidelines, but we need to make sure we're aware of the payer guidelines and our state guidelines in order to really be properly following all of these rules that we have in place for us. Also, of course, we recommend a consent to treat, and I'm going to give you a glance at what that looks like. And we're going to go over some common coding for some of these commonly performed investigational and experimental procedures. So if you're wondering from the very beginning slide that we started with is what do you mean unproven? How could it possibly be unproven? It works in my office. I've done this for years. And actually, the interesting thing about this is unproven isn't necessarily because there's not clinical evidence. Unproven means that there hasn't been the process that is required by the FDA and by other governing entities in order to submit so much clinical evidence, so many publications and specific types of in publication, magazines, books, and different research areas like that in order to qualify it as a proven procedure. So it's not necessarily by our definition that it's considered unproven, but it is by those governing entities. So actually who decides? And really the bottom line is a lot of it is the FDA and the other governing entities, and they ultimately decide what is unproven and what's a proven procedure. And quite truthfully, in order to become a proven procedure, again, it goes through this very rigorous, very expensive, and very long process to meet all kinds of different criteria that we're not going to spend time discussing today. But in order to really be deemed by the Federal Drug Administration as a proven procedure, if a type of procedure either doesn't go through that expense or doesn't qualify for that, most of the times they don't even attempt it because it's so expensive and so exhaustive that these procedures, while they may be working in your practices, are deemed unproven. That being said, it means your third-party payers are not likely to cover, in fact, almost never likely to cover and pay for unproven procedures. So there are some of these procedures like the Graston technique, activators, active release. So what does that mean? Well, all of these procedures by multiple of your third-party payers are actually considered unproven and investigational. So let's go ahead and jump into that a bit more while we're starting to grab your attention with some of these procedures that you may be rendering in your office. So let's look at the actual definition of experimental, investigational, and unproven procedures. It's defined as use of technology, drug, device, or treatment or procedure that has not been recognized as having proven benefit in clinical medicine for any condition, illness, disease, or injury being treated. Now, again, this is the official definition of unproven procedures, and you may kind of be rolling your eyes a bit at that because it's working in your office, so you've proven it time and time again with all of your patient testimonials. Not going to qualify for being a proven procedure according to coding, documentation, billing, and third-party payer guidelines. So in other words, to translate this, this could be just a simple supply, procedure, therapy, or device whose effectiveness has not been demonstrated by required scientific evidence and properly authorized by the governing entities like the FDA. So this is basically what I was saying to you just a moment ago, in order to be acknowledged as medically effective for the improvement of function for specific conditions or treatment. Multiple examples of this are things, the Beamer mat, laser therapy, the hot laser a lot of times, dry needling. We could go on for a long time, and I'm going to show you multiple of these lists as we continue on through this session. But again, there's a lot of things that may or may not be happening within your office. A lot of chiropractic offices do tend to step outside of the traditional chiropractic and offer some type of therapy or alternative treatment that is deemed unproven. But again, even those traditional ones that we would not ever in our wildest dreams guess to be unproven is unproven. So we'll look at those today. So it's not meaning, again, by the definition that these procedures are actually unproven, and this is just really reiterating to you that just because by governing entities it says it's unproven doesn't mean it doesn't work. It just means it hasn't met the specific criteria in order to qualify it as a proven procedure. With that being said, doesn't mean we can't perform these procedures in our offices, doesn't mean that it's not beneficial to the patients. It does mean that it's going to affect a lot of times how we document and how and if we bill to third-party payers for these types of procedures. A lot of this is simple, just following the policy, but there's a major risk management to this in practices that we often overlook simply because long-term billing of unproven procedures as though it's a covered and proven procedure, not if, but when an audit or record review occurs, it's almost guaranteed that your office is going to find themselves in a situation that you're not able to explain or defend. And if you feel compelled to even appeal a denial, the ability to appeal is really completely non-existent simply because then you're opening up, a can of worms, because ultimately your documentation is always going to be one of two things. It's going to be your saving grace because it's completely and fully defining, meeting the medical necessity and documentation guidelines and telling the same story as the codes in your claim form, or it's going to not be telling the same story as the codes in your claim form, and therefore opening up a big can of worms and resulting in, a very sometimes long-term process of, stress, expense, and things like that in order to defend or support why your documentation and claim forms aren't telling the same story. And a lot of this boils down to multiple of reasons, but certainly providing unproven procedures is one of them that I run across on my desk on a regular basis. So why does unproven procedures affect reimbursement? And the reason is just that I have been saying all of these third-party payers that you're currently billing have a chiropractic or have a therapy and have an unproven procedures policy. Most of the time, the unproven procedures policy for chiropractic is listed right in that policy for chiropractic procedures for that particular carrier. Most insurance companies also review and update their third-party policy every single year. That being said, if you haven't looked at yours ever or you haven't looked at it for a while, now would be a good time to make a list of all of those third-party payers that you currently bill to and pull your current chiropractic policy and even therapies policy if you're performing any other therapies in your offices. If anyone on the line is multidisciplined today, again, same thing, make sure for all of those specialties that you are submitting claims for, pull those payer policies and make sure that you review them. When I do it, I like to go through with a highlighter because there's almost always something in there that's either a great reminder to me or something brand new that didn't exist last year. So this is, again, major risk management piece. We've talked a little bit about defining care, and I mentioned earlier in this webinar already that it doesn't mean that these unproven procedures don't work, but it does mean that we have to, fit within the guidelines of the third-party payer. So that's really based upon the graphic that you're looking at now. There's really three levels to how we would look at this. One, the big bubble is what's clinically appropriate. So we have a lot of latitude of what we can do with our patients and what we'd like to do with our patients and providing them services and that type of thing. But then we boil it down to what's medically necessary. And in order for a third party to be able to pay and for us to be able to compliantly bill, we have to make sure that we're meeting those medical necessity guidelines. So that's going to narrow down in a lot of practices what we're really able to code and bill for properly if we're expecting third-party reimbursement. But then we go ahead and boil it down to one more smaller piece, which is medically necessary according to that third-party carrier. The fortunate piece to this is most third-party carriers do define the medical necessity piece much the same way. On the same token, the reason that I'm recommending to you to review all of those third-party payer policies is because they don't always define them exactly the same way, and there are variances based on every payer, which is, again, a risk management area that we need to be aware of in our practices because you can really close in a big gap and protect your practice a lot just by knowing what those third-party payer guidelines are. Now, of course, not to deviate from our topic at hand, but this truly applies to even your traditional services that are not deemed unproven, experimental, or investigational, but certainly those that are listed within these policies and something we most definitely need to be aware of. So let's take a look now at a few of those examples. The Cigna Chiropractic from Minnesota has gone on to define the type of treatment described. Go ahead and feel free to read that graphic there to the right of the screen. I'm not going to go ahead and go through and read all of that for the purposes of time, but it does define what successful treatment would be considered, what is considered chiropractic manipulative treatment and therapies, and it talks about what types of therapies are being covered and what is considered medically necessary. So again, going through all of your policies, you're going to find bits and pieces in that, and in the event you're requested for records or in the event you find yourself in an audit, this is what your records are oftentimes compared to, not just the typical standards for documentation, but that payer policy is actually sitting right there with all of these items as well to make sure that you're meeting those guidelines as well. Also, Anthem of Minnesota, just bearing in mind too that there's so many different groups of Anthem. This is oftentimes, most of the time, actually broken up into individual states, and most states have their individual guidelines, but some of them use different types of managed care. Within that are these specific payer policies that I'm referring to that's going to go ahead and define for you what is considered medically necessary and specifically what is considered investigational, experimental, and unproven. Also, going into, this goes outside the Medicare and Medicaid services, but it says that chiropractic treatment must be as effective as other types of treatments. And so going through just the traditional chiropractic, they have a really pretty fine line on what is considered medical necessity. And again, making sure that your documentation is valid and compliant. You want to make sure that you're reviewing that medical necessity piece as well. United Healthcare is another one of them that is, it's an individual policy that's widely billed to among chiropractic, and again, going through to review what those particular payer guidelines are in your area is going to be beneficial for you and for your practice. I may go ahead and just skip past a few of these. There is a couple of slides I really want to make sure to get to in the time that we have. But here with United Healthcare of Minnesota, they do say here that manipulative therapy is unproven and not medically necessary in the treatment of non-musculoskeletal disorders such as asthma, infantile colic. I've actually recently had a practice that had undergone a really difficult audit because they had been submitting claims for colic of an infant and using that as a diagnosis code. And of course, in this payer policy, as well as almost every one of them that I've ever read, that's considered an investigational type of procedure, and this practice had to reimburse a lot of money back. And so make sure that you know the diagnosis that you're able to use as well. Something like this could certainly be included in the documentation, but sticking with those musculoskeletal findings is what you need to do in order to make sure that you're supporting medical necessity properly and avoiding investigational type of care. Also, TMJ disorder, correction of scoliosis, craniosacral therapy. Again, this is just United Healthcare of Minnesota. I'm going to show you one of Aetna here before long that's going to just blow your mind. But regardless of that, manipulative services that utilize non-standard techniques such as AK, NUCA, network, and other organizational and neuro-organizational techniques, so the NET techniques. This is what we're going to, these are all deemed as experimental and investigational procedures. A lot of the records that I review tend to have these types of things abbreviated or documented. Meanwhile, the practices are billing this type of care as your standard extremity adjustments, regular CMT, the 989404142, and other types of codes that are paying codes, not realizing that these are considered unproven procedures. Going into the Aetna review policy, this is actually my favorite one to share with you, and I want to, oops, my slides just blinked out on me. Okay, I want to show you on this particular Aetna policy. They review it. You can see on the right side of the screen that it's reviewed every single year. The next review was April of 2018, and I keep checking for the most recent one, and I'm not finding it. So as soon as I am able to obtain that, I'll have it updated here in my slides. But they go on to talk about chiropractic procedures and the types of services that are experimental and investigational. So let's go ahead and look at this. Aetna actually specifically says they consider the following alternative medicine interventions experimental and investigational because there's inadequate evidence in the peer-reviewed published medical literature of their effectiveness. So let's take a gander at that. Of course, you see the few that I have highlighted, but this list is long and distinguished. So take a glance at that as I continue just explaining. But, acupressure, ART, applied kinesiology, aromatherapy. So there's some of them that you would probably expect to be investigational, but certainly some that raise our eyebrows. Biophotonic therapy, LED, brain integration technique, craniosacral therapy, colonics, color therapy, a lot of different types of things that you may have, been heard about or be using in your office. Cupping, the crystal healing, ear candling, flower essences, all types of the gemstone therapy, all types of of therapies along those lines, again, in this very long and distinguished Aetna policy. Grafton technique, the human placental tissue, humor therapy, all, again, as we go through these, just bear in mind, some of them I haven't ever even heard of before. Hair analysis is an experimental, and our offices did lots of hair analysis over the years. Hydrogen peroxide therapy, hypnosis, live blood cell analysis, magnet therapy, all of these types of things considered experimental and investigational. And this is literally pulled off pages of the most current Aetna policy. Meridian therapy, muscle testing, myotherapy, all of these are, and again, you can see the other list, so there's probably some you recognize. I'm just not taking the opportunity to read. NUCA, Reiki, Rolfing, all of those things still considered experimental and investigational. Therapeutic touch, visceral manipulation, whole body vibration, vascular, endothelial cells therapy, and multiple of other ones like that. Aetna even goes into a deeper level with ART, and they supposedly allow providers to identify and correct specific problems that are affecting each individual patient. And it's different from conventional chiropractic manipulation according to this study, and therefore because of that, this one report, ART, is determined that it did not reduce inhibition or increase the strength in the quadriceps muscles of athletes, and therefore further study is required, and ART as such is deemed to be experimental, investigational, or unproven. Going on with some more experimental and investigational procedures of Aetna, the Atlas technique, Cox, cranial manipulation, all of these that you see on this list. Manipulation of infant colic, so we talked about that. The networking technique, NET, SOT, spinal adjusting devices like the Pro Adjuster, the Polestar, the Activator, the wobble chair, craniosacral therapy, up-ledger technique. Any specific technique that's named after a person is probably going to be on this list somewhere as deemed as experimental or investigational. And a lot of, chiropractic providers, especially early on, had developed their own techniques, and they land on this list once it becomes a widely used technique and it becomes showing up in documentation. And then all of a sudden, the FDA, governing entities, and third-party payers evaluate the technique and the research on the technique and determine that it hasn't gone through this process that we talked about to be considered proven, therefore falls on the unproven list. Going into another third-party payer, just to give you an example, Blue Cross Blue Shield of North Carolina considers therapeutic modalities that are not covered as counseling, low-level laser, which is also the same as cold laser, which is commonly listed as an investigational procedure, dry hydrotherapy, also considered, which is your Aquamed and your massage, those water massage tables that offices have, all considered to be the hydrobeds, to be an experimental and investigational. Blue Cross Blue Shield of Alabama also has a very similar type policy. Again, not to inundate you with a whole bunch of policies that don't specifically apply to you, but certainly show you the very long and distinguished list of policies that do have very clear and specific lists of what is considered to be experimental and investigational, and therefore not payable by those payers. That, again, is all the more reason to make a list of those payers that you're billing and make sure that you have your current policies printed, reviewed in your compliance manual, and you're aware of what is considered medically necessary and what's considered experimental, investigational, and unproven procedures. Also, the roller traction table is not a covered treatment, so this is actually an example of this. It does not meet the Blue Cross Blue Shield of Alabama medical criteria. Same thing applies for almost every other third-party payer out there. So examples of services include automatic massages, including the Aqua Massage, hot and cold packs, which is something that's kind of come about over the past several of years. And honestly, the reason for the hot and cold packs was because it was being billed all the time as a routine part of treatment for practices. And so all of a sudden, when third-party payers started realizing there was a lot of lost money, they started looking for that low-hanging fruit. Actually two of the obvious ones include the traction roller table and hot and cold packs. And the reason for those is because it's performed or was performed on almost every patient on almost every visit, regardless of their phase of care. So it was determined that these were performed for routine purposes and not purposes of medical necessity. Therefore, they fall into the unproven procedures category. So use of some exercise equipment, repetitive exercises, group therapy is listed, all kinds of things like that on these types of policies that we definitely need to be aware of, especially based upon our practice type. So there's a picture of one of those roller tables. Also, moving on, there's some compliance considerations. We talked already about the third-party payers and their expectations for a clean claim. A clean claim doesn't just mean that it's coded properly, but certainly you must have the appropriate service codes and modifiers that define what is provided within the documentation, supporting diagnosis codes for the services that are rendered, because like I've mentioned before in these webinars, your service codes say what you're doing, your diagnosis codes say why you're doing it, so you need to make sure that you're properly diagnosing for the services that you render. And of course, boiling down also to that piece with documentation that I mentioned earlier, you want to make sure it's your saving grace and not your big can of worms. It needs to tell the same story as your coding and be consistent with compliance guidelines, not just for documentation in your state, but certainly with your third-party providers. I see a question on here that how do these rules apply when treating as an out-of-network provider? Excellent question, and I'm glad that you posted that. These rules apply exactly the same regardless of network status. So the insurance payers don't have any care at all whether you're a network provider or an out-of-network provider. What they care is that they're receiving claims from you with the expectation that they're going to process and pay for medically necessary and covered services. So regardless of your provider status, this is something that you most definitely need to be aware of. Now to move on, as I've mentioned a few times already, that you need to make sure that you're listing those third-party payers and pulling up those policies. Very easy to find them. Here's the steps that you see on the screen, but basically all you have to do is Google it. When I look up the Aetna chiropractic policy, I simply type in Aetna chiropractic policy, and there it is. If it's Blue Cross Blue Shield of Colorado, I type it in Google, and it pulls right up there for me, and I'm able to save that or print it and review it. So super easy to do. You can find them yourself. Certainly if you need help, reach out, but otherwise it really takes just a matter of seconds to pull these. I like to put it on my calendar every single year every new year to pull those new policies. If there happens to be one that's not updated, like that Aetna one keeps not updating properly, then I'll just put myself a reminder every month to go and check again until finally Aetna gets the most latest and greatest one up there for me to save to my computer, print, and highlight all over it. So we talked again about our unproven and medically necessary procedures and determining what's clinically appropriate. Those three bubbles that I showed you early on really just defines this, but just to make sure that I've made that point clear, even though it may be clinically appropriate to you, even though it may be medically necessary to you, even though it may be a proven procedure to you based upon your own experience, expertise, research, and findings, does not mean that it meets the third party or any other governing guidelines. And so that's a challenge that we run across all the time in chiropractic. And it's simply because we know what we're doing works with our patients. We believe in it, and we're getting a lot of patient testimonials, and we're finding success in patients by these different techniques and procedures that we're performing. Just understand that the bottom line isn't that these things don't work. It is that we're not having to follow our own rules for meeting medically necessary proven procedures and all of those types of things, but we're having to follow the rules of those governing entities and those third-party payers that are issuing payment to our patients and ourselves for these services that are being billed in. That brings up just one more point to me. I do get asked sometimes, well, patients self-submit, so if I just give them codes or the closest codes that we have so that they can get reimbursed, doesn't matter. It still makes you liable simply because you're the one who's assigning codes to it. The patient would have no way to know what codes to assign or how to do that on their own. So you are the one who's ultimately responsible for the codes that end up on those self-submission forms that you're sending to your or giving to your patients to submit. And again, the insurance company doesn't care necessarily who they're paying. They care that they're paying. And ultimately, as the provider or the practice, you're going to be the one liable if those codes that your patients are self-submitting based upon what you provided to them are not accurately supporting medical necessity, are for or unproven or investigational type procedures, or aren't supporting the documentation that you have. Again, you can always be requested for documentation regardless of your provider status in or out of network. And even for cash practices that you have self-pay patients, happens all the time, and just being aware of those things is extremely helpful to you. Moving on with that, I mentioned already that you can be requested for records. There's one other corner of the world that you could be requested records from besides the third-party payers, and that's your state board, and they have rules as well. So Colorado, for example, I'm going to show you simply because I live in Colorado and I'm into this one all the time, but they have very specific rules regarding unproven procedures. So it's quite possible or probable that your state may as well also have something very similar to Colorado. And I want to show you what that looks like. And you're going to see, once you look at Colorado's with me, why it's going to be important for you to reach out to your own state board to get those rules. The nice thing about most of these state boards is certainly if you're a member, you can usually find this type of information super quickly just online, but otherwise it typically takes nothing more than just a phone call in to get the information you need and make sure that they send it to you by mail or email so you have it for your own records and review. This is what's interesting about Colorado. They actually list procedures that are unproven, and in Colorado's law, they also say these types of procedures require an informed consent from the patient, which lets the patient know that these services are unproven, experimental, or investigational. So Colorado goes on to define what a proven procedure is, and I think for the purpose of what we're talking about today, it's going to be helpful for you to sort of see a bit of that process that it takes these types of procedures or items or products to go through in order to become a proven procedure. So Colorado says that the procedure is taught in the regular curriculum of at least one college in chiropractic and approved by the Council on Chiropractic Education. If the procedure is based upon anatomical, physiological, or structural relationships, which can be verified through standard diagnostic procedures, super important because standard diagnostic procedures is often deviated from not just in chiropractic, but certainly in chiropractic when this is something that Colorado has recognized and listed as a requirement. And also the procedure must be supported by a body of evidence using standard scientific research methodology. So publication in a peer-reviewed professional scientific journal, and they give some examples of what that would be. Supportive preliminary results, an investigation in process sponsored by some type of agency, and a hypothesis clearly derived from supportive literature. So this is just a few of the things that it takes a procedure or some type of product or item to go through in order to be officially, have to pass all of this, of course, to be determined as a proven procedure. Otherwise, it is automatically deemed as unproven. The Colorado rule goes on to say, again, this informed consent is limited, must include procedures like soft or cold laser for uses not approved by the FDA. The laser is something that I could spend a long time talking to you on. LED is something that a lot of offices have, and they call it laser, and it isn't laser. There's also cold laser and hot laser and variances within that, so you need to make sure that you know what you're using. Infrared is another major issue for that, because if you're using an infrared unit but calling it laser or vice versa, that's not the same thing. So make sure that you know what that is and that you're using that properly, and if your state requires an informed consent, that you go ahead and implement that. But here's again to go on with that list here in Colorado. Again, go ahead and review it along with me. I'm not going to read every one of them, but just to give you some idea of what a specific state organization would deem as an unproven procedure. And they also go on to say that this isn't an exhaustive list. And so they give you the ones that probably have crossed their desks the most, and then they leave it open-ended, saying that there are, not limited to these that we have listed specifically here. Another great example is the foot bath. Those of you that have used the foot bath machine that pulls the toxins out of the body through pores in your feet, used to be super popular, probably still is in a lot of offices. This is an unproven type procedure, and in Colorado at least, as well as many other states, would require some type of informed consent to let the patients know that while this procedure may be beneficial by governing entities, it is deemed an investigational, unproven, or experimental procedure. So what I would recommend to you personally is, even if your state, well, first check your state to see if there is a specific rule on informed consent for unproven procedures. If there is, obviously use that language for your state and implement an informed consent for that as it fits your office. You don't need an informed consent for every single unproven procedure that you provide. You can certainly encompass all of them onto one informed consent for your patients and use the appropriate language to let them know that while this may be beneficial, these are the governing entities that deem it an unproven procedure because it hasn't met all of these specific guidelines. But otherwise, if your state doesn't require an informed consent, just for the purpose of communicating properly to your patients and for the purpose of risk management, I think it would be an excellent idea to implement an informed consent anyway, and that way you always have record that you have very clearly communicated to your patients what you're doing with them, what procedures are being rendered, what the expected benefit of the procedure is, and they're in full front-up understanding of what that is. What you don't want to have happen is a patient find out later that, you know, they're Googling about something and find some funky type of information on a procedure that you're rendering, get upset with you and feel that they've somehow been misled, and then call their state or call your state board to complain about it. So this type of informed consent is, you know, sort of foreseeing what could happen and minimizing your own risk in that. So making sure that you properly disclose to your patients is really the bottom line with the informed consent, and that's why I think it's a great idea to implement it, even if it's not mandatory. And there is a support tool that you'll see from KMC University that actually just defines this particular one I made that has just a general list of unproven experimental and investigational procedures that are common in a lot of offices, but again, not an exhaustive list. You're going to want to customize something like this for your office. You certainly don't want to have something on it that you're not rendering in your office, but those that you are, very good idea to go ahead and identify those and make sure that the patient understands that we do believe this is beneficial. Here's, if they want research about it, if they want additional information, to inquire with your staff or with your office. But according to federal and state guidelines, these procedures are deemed unproven, investigational, or experimental, and as such, you're communicating with the patient so that they are in understanding of that and understand that they're voluntarily receiving these services. It also goes on to let them know that because these are experimental procedures, they're not likely to be covered and paid by third-party payers, and so this covers a bit of the financial piece for your patients as well. So let's take just a few moments in our last few minutes here to discuss the coding and billing segment of this. You always want to do your research first. So the best thing to do is to determine what type of service that you're offering. That picture on the right there is of a PEMF machine, and you're going to want to know if that's a codable procedure. Codable means a procedure that there's actually a very specifically defined code for that procedure. If something isn't codable, you have the responsibility to determine what the closest code is. This is why in the coding manual, we have a handful of unlisted type codes that are specifically for procedures that are unproven or investigational, or that do not fit within the definition of the typical services or procedures that are being are deemed proven, or services or procedures that are defined within coding. That being said, your PEMF machine would typically go in as a 97139, some type of unlisted type of procedure, simply because unlisted means it's an ill-defined or undefined procedure, and therefore anything that you're doing can be used with that code. At the same token, it's not likely to be paid, but it does hold you in compliance with those coding and documentation guidelines. Also, of course, we need to bear in mind that there are elements to a payable claim that we need to consider those as we're determining how we're documenting, how we're coding, and how we're communicating with our patients about the services that we're rendering in our office. And I want to just take a moment to show you those elements to the payable claim. The first one is the services were actually provided. Again, this goes down to your documentation and coding telling the same story. If you happen to be using a code that isn't clearly defined in the documentation, this would be a clear indicator that there's a service being billed for that wasn't provided. this is an element to the payable claim and certainly among the top of that list. There's no statutory violation. So example would be your Stark Law, Federal Anti-Kickback, your False Claims Act, and all of those types of guidelines that we're required to follow. Care also must be medically necessary. And again, going back to that medical necessity description, my best recommendation to you with understanding medical necessity is to go to those payer policies and review medical necessity descriptions for each of them. It's usually right close to the top of those chiropractic payer policies, simply because medical necessity is really the foundation of everything you're going to be able to document properly and code for and bill for and expect payment. So going down and looking at that, and it is the nice part about that is the description of medical necessity is pretty much identical for everyone, so you're not going to find a great deal of variance in that, and that's going to be helpful. But reviewing that on a routine basis is going to be huge for you. The next thing to a payable claim is make sure that you meet all the coverage rules. You certainly aren't able to do that if you don't know what they are, and that's why we go through those chiropractic policies at a minimum of once per year or at least once per year, just to make sure that you do have all of that current criteria and you're understanding what you are able to do within that particular payer guideline. Also properly coded. I've covered this a number of times already, but again, just to reiterate in a very simple manner, your coding says what you're doing, your diagnosis say why you're doing it, and your modifiers at the ends of your codes actually give more information. So if you might imagine yourself reading a novel, the more detail and descriptive adjectives and those types of words in the novel, the more in your mind's eye you can see the characters, the setting, the plot, and all of the details taking place with that. Your documentation and claim forms is the exact same thing. It tells the story in the life of that patient in your office in that day. So that's what modifiers do. It gives additional detail to help really paint the picture of what's taking place and why with your patients. And finally, the last one is this properly billed. This really goes all hand in hand, but we want to make sure that we have all of these pieces in place so that we're able to submit correct and clean claims. Some additional things here, there's usually no third-party benefits for those DRX machines, and so there's long and distinguished information and articles and information within payer policies on the DRX machines or like-kind machines. So there's often not a specific code available in the HCPCS. This is why the patients pay out of pocket, and we would default to then what would be an unlisted procedure code. Let's look quickly at a couple of common examples. Laser, again, like I mentioned, I could carry on for this one for a good while, but we have our laser. It's not LED, it's not infrared, it's not hot laser, but the HCPCS code for cold laser therapy, that's true cold laser, is our S8948 code, and it is a time-based code, which means in order to bill that code, you need to make sure that you meet the minimum guidelines for that. Since we're not able to use that 52 reduced service modifier anymore, you have to perform these time services for a minimum of 8 minutes in order for that service to be billable. Hydrotherapy is another one. So this is also known as your aqua massage and hydrobed, not the same as Whirlpool. It's not massage. There's all kinds of reasons. It requires little to no clinical skill, no training. You find these things in shopping malls that you pay $1 a minute or something like that for to do. That's why these are considered unproven procedures, and the best code for that is your 97039, which is an unlisted modality. All right, let's going on. If you are a member of KMC University, they've actually taken the time, or we rather have actually taken the time to go on to define some more hydrobed information in a bit more detail, because these are popular in some practices, and there's information that we need to have in order to be compliantly using and most importantly compliantly billing for those, which again is going back to that 97039 code. Another one that I love is kinesiotaping, because I run across all the time offices that are using the wrong codes for kinesiotaping. So I want to give you some information that I was able to dig up for some webinars a long time ago that I wanted to share with you today. Kinesiotaping is intended to provide pain relief, stability, support, improve recovery from injured and sore muscles and joints, and this is really important, without sacrificing freedom of movement. So the patient is still supposed to have their range of motion, but kinesiotaping is supposed to help remove the pain and relieve pain and that type of thing. So let's move on to the next slide, because this is why this is such a big deal. The strapping codes are often billed for kinesiotaping, and strapping codes is like our 229 codes. Strapping is defined, and this is online. It's in the medical references. You can find it yourself if you'd like to double check me. But strapping is defined as the application of adhesive plaster on or around an area served as a splint, and its goal is to reduce motion or hold surgical dressings in place. So the goal of kinesiotaping and strapping is completely the opposite, and that's why your strapping codes are not appropriate for kinesiotaping. So please, if you're using those, unless your payer policy very specifically says that these are the codes to use, please do not use them, because you will find that in the event of an audit, you're going to have a difficult time explaining yourself. Most third-party payers also deem kinesiotaping as experimental. You saw that within the third-party policies that we reviewed. Strapping is not considered experimental because it's used for a specific separate purpose and has actual defined codes. So as we're billing for kinesiotaping, here's what I would recommend to you. First, I want to just share with you, this is actually from the Optum policy, and they say kinesiotaping therapy is unproven and not medically necessary due to insufficient scientific evidence of effectiveness. And again, this is, you're going to find this everywhere, but I wanted just to share this with you because I'm always asked, prove it, where does it say that? So here's one example, but there's a lot of them out there. But here's how you'd actually bill correctly for kinesiotaping. The best code is 97799, which is an unlisted physical medicine rehabilitation service or procedure. But with that being said, you can also bill for the tape. So there's non-waterproof per 18 square inches and waterproof tape per 18 square inches. And so this is how you would appropriately and correctly bill for kinesiotaping if that's something that you do in your office. Also, the axial decompression traction is not accepted by the third-party payers. That's our 97012. I touched on the traction a while ago. That tends to be, not that it's an unusable code, but it is one that is highly scrutinized upon simply because it's slapped into the wrong places and it's used to define the wrong services, but also it's one that is subject to audits because of the multiple findings of it being performed for routine purposes rather than medical necessity. So again, unless your third-party payer, actually you use one of these three codes based upon what your third-party payer tells you to do, you'll find it within those policy guidelines. It could be the S9090, which is actually specifically for the axial decompression, so your DRX type of machines. If this code, the S code, is prohibited, as it is by some third-party payers, you could go with your unlisted modality, your 97039, or perhaps even your 97799 unlisted physical medicine rehabilitation service or procedure. Most of the time you'll find within your third-party payer policy that they tell you which of these three codes they want you to use if you use a decompression machine. So finally, as we go ahead and conclude today, I do see that there's a couple of questions, and the best thing to do is submit those to helpdesk@kmcuniversity.com. They will make sure to get them to the correct person. And I'm just going to check with Christy here. Do I have time for a couple of questions, Christy, or are we out of time completely?
No, absolutely. Take a few questions.
Okay, perfect. So how can we get a copy of the template for unproven procedures? Go ahead and just submit your request to helpdesk@kmcuniversity.com, and they will make sure that that gets to you. And if we're doing an unproven procedure and let's see, are we fine to collect the fee from the patient at the time of service with having the informed consent, even if we're in the PPO network? So what you need to do is review your contract if you're in the network. Most of the time, what practices do for services that are unproven procedures, if the patient voluntarily says they'd like to receive that service, of course, collect the proper authorization and, go ahead and collect the fee for service from the patient. At the same token, CHUSA provides a great advantage for services like that as well, and Chrissy could certainly touch some more upon that if she has a few moments to do so. And that actually concludes all of the questions. And so I'm going to turn this back over to Christy to cover any of those pieces that you'd like to. And thank you all for joining me, and I look forward to being back.
Thank you so much, Brandy. And I can't thank you enough for taking the time out of your incredibly busy schedule because I know exactly how busy it is, especially right now, for being here today and doing this webinar. Um, she's got a lot of stuff going on today, so we are very excited that she was able to have this window of opportunity in her schedule today to do this presentation. And you can bet you will see Brandy again later this year, and definitely in 2019. One of our highest rated speakers, always talking to us about different aspects when it comes to, again, documentation, coding, and compliance. So if you have want to see some other webinars that focus on those aspects, make sure you're filling out the survey at the end of the webinar. Tell me what webinars you're looking for, and we'll get with Brandy and we'll see what we can make happen. Brandy did mention, when it comes to those non-covered services or unproven procedures, that Chiro Health USA absolutely can help, and we most certainly can. This is a webinar series sponsored by Chiro Health USA, but it is not about Chiro Health USA. So, Claire, if you want some more information about how that would work for you, or if anybody out there who's possibly not using Chiro Health USA but want to know more about that, just shoot me over an email. Y'all can reply to the email that I sent you earlier today about just a reminder for the webinar, and just say, hey, can you let me know how this would work, because I'll be happy to answer those questions one-on-one. But I want to make sure that we keep our focus. So I am so thankful Brandy did. That is what we do, help for those non-covered services. I want to remind y'all that, we're back into the swing of things in July. We've got a lot of great webinars and a lot of new speakers coming to the webinar series. So next week we have Dr. David Jackson talking about raising the perceived value of chiropractic in your practice. This is an excellent webinar. I am so excited. He did this webinar a couple of months ago. I sat in on it, just blew me away. And so I was so excited when we were able to work it out for him to be here next week. Then the following week, we have my very good friend, Dr. Alan Sokoloff, who's going to be here talking about surviving and thriving in sports chiropractic, which is very near and dear to my heart. Sports chiropractic has been so tremendously beneficial. Many of you have heard me tell the story about my son, who is very active, athletic. He broke his leg, and it was through a sports chiropractor with therapy and rehab that he was able to fully recover from that. Not that his incredible orthopedic doctor wasn't awesome, but my child was under the age of 12, and they said he didn't need PT, and chiropractic was just absolutely amazing, because I don't know if he was more broken before or after, during or after the cast came off, but chiropractic changed his life and really improved his game, to hear him tell it at 12 years old. And then at the end of the month, we always have to talk about Medicare, because we always have lots of questions about Medicare, and we have Dr. Steve Conway and Dr. Scott Munsterman, who are going to be here. And it says 99% of your Medicare questions answer. And they're going to take the most common questions that we get about Medicare and chiropractic and answer those. That one already has an unbelievable amount of registration. So if you have not registered, go ahead and do so, because even if you can't attend live or you're going to be late, you will get access to the recording. But we have webinars posted all the way through September, with more being added every single day. So check those out at chirohealthusa.com /webinars. Again, I want to thank Brandy and the team at KMC University for always being so willing and flexible to jump in, be a part of our webinar series. If you haven't visited the KMC University website, you absolutely should. It is one of my top go-to websites that I visit on a weekly basis. They have a lot of incredible free resources for you, a lot of great FAQs. They have an incredible blog. You should be following them on Facebook too. They answer questions on there all the time. Their library, unbelievable. Like I said, Kathy Mills-Chang and her team are just unbelievable and out of this world. So I really do encourage you, visit kmcuniversity.com, email the help desk at kmcuniversity.com if you want to get access. to the template for the unproven procedures. If you have any additional questions, you can email the help desk, and they'll get those to Brandy or another specialist at KMC University who will quickly answer those questions. Unbelievably helpful, top-notch customer service. Like, love everybody at Team KMC. So I hope y'all have an amazing rest of your day, a fabulous week, and I look forward to seeing y'all next week. Bye-bye, everyone.